Hello everyone, this is Katie Lucas. Happy CREOG studying. I'm going to be briefly going over sexually transmitted infections. So this is a review of common infections, a review of some screening guidelines per the CDC, and briefly talking about expedited partner therapy. So a little bit about disclosure for this. This is by no means a comprehensive review of common sexually transmitted infections. I still would recommend you refer to additional review materials for more specific information that may be pertinent to the exam. Additionally, we will not be discussing congenital infections, HIV, or hepatitis, as these have a lot of information. So again, I would recommend you review some of these things prior to the exam. Congenital infections typically are tested on every year. So a little bit about screening guidelines. So the CDC has recently been putting out new recommendations in terms of sexually transmitted infections, and it's really important to remember about who we need to be screening. So all sexually active women less than 25 years of age should be screened annually, including gonorrhea, chlamydia testing, and any additional serum testing they may want, including HIV, hepatitis, and syphilis. Women who are greater than 25 years of age can be offered sexually transmitted infection screening if they are baseline risk. Women who are increased risk are those that are over 25 with a new sexual partner. They have more than one partner at any given time. They may have a sex partner who also has concurrent partners, or a sex partner who was recently diagnosed with an STI. That would be considered an increased risk. HIV screening we're not going to touch upon here, but again, everyone knows guidelines for when to start HIV screening based on age and risk assessment for HPV. Screening guidelines specifically for special populations. Pregnant women, as again we all know, routine screening is recommended at the new prenatal visit, including gonorrhea, chlamydia, HIV, syphilis, hepatitis, and in most places trichomonas as well. For transgender, gender-diverse persons, so routine screening is recommended in all persons with a cervix less than 25 years of age, as we described above. So annual screening for sexually active people less than 25 every year. If they have increased risk over the age of 25, they should also be screened routinely. HIV positive patients have more specific guidelines and recommendations for the frequency and type of screening they should have, as HIV patients are at higher risk for having other concurrent infections like syphilis, trichomonas, gonorrhea, chlamydia, but at the very least should be screened annually for gonorrhea and chlamydia. What's not recommended outside of pregnancy or HIV positivity is trichomonas. So most people don't routinely have to be screened for trichomonas. So a lot of our STI panels, particularly the vaginal swabs, also have concurrent trichomonas in them, as we see at the MFA. Herpes virus also isn't routinely screened for, as you'll see later in this talk, that there are a lot of people out there who are seropositive for herpes virus and aren't symptomatic. Unless there is lesions or concern, then we do not have to routinely screen patients for herpes virus. A little bit about expedited partner therapy. So the definition is the clinical practice of treating the sex partners of patients diagnosed with chlamydia or gonorrhea by providing prescriptions for medications to take to their partner without actually examining that partner. So laws about who is allowed to prescribe expedited partner therapy is state specific. It's, as we know, accepted in Maryland, DC, and Virginia. So we should be able to do this freely for our patients and their partners. In cases where gonorrhea, expedited partner therapy is permissible, meaning in all of the areas that we're practicing in, if you feel the partner is unlikely to seek treatment. So sometimes these are scenarios where you ask the patient specifically if they're in touch with their partner. It's good to know this information, that you can also prescribe them an 800 milligram single oral dose of cefixime, instead of the IM preferred dosing of ceftriaxone that is been recently published by the CDC in terms of new recommended guidelines for 2021. So you can provide them with an oral prescription for this, cephalosporin medication that isn't the preferred dosing, but it's better than nothing if you feel like the patient's partner isn't going to be seeking treatment. If the patient tests positive, then you need to prescribe the partner a course of antibiotics for treatment of chlamydia as well. So the preferred regimen is doxycycline for 7 days, but you can also give them, which is what we routinely do, is give them the 1 gram, 1 dose of azithromycin, which is a little bit easier to make sure that the partner is compliant with. So a little bit about chlamydia. So this is our first discussion of our first organism we'll be talking about. So Chlamydia Trichomonas is a gram-negative intracellular bacteria. This is the microscopy of the intracellular bacteria on a slide. It's the most commonly reported sexually transmitted infection in the United States. The incidence rate reported in 2018, according to the UpToDate, was 539 cases per 100,000 people. It's also very important for us to remember that it's twice as prevalent in women as compared to men. And the highest prevalence is among women ages 14 to 24. So again, women who are less than 25 years of age should be screened annually for chlamydia if they are sexually active. Manifestations: the majority of infections from chlamydia are asymptomatic, but the patient can also present with cervicitis, urethritis, pelvic inflammatory disease, and then what typically tends to be more of CREOG fodder is the Fitzhugh-Curtis syndrome. They have perihepatic adhesions, which actually I did see on laparoscopy just last week on a patient with an ectopic pregnancy. So it's pretty prevalent out there. It's very interesting to see in real life. Diagnosis is usually nucleic acid amplification testing. This is in the way of either a vaginal swab, endocervical swab, or a dirty catch urine can also be admissible. You should also be testing for concomitant gonorrhea, which most testing will combine. An up-to-date recommendation from the CDC in 2021. Again, the preferred regimen for chlamydia is a 7-day course of doxycycline 100 BID. However, if you feel the patient is not going to be compliant with the treatment or they're pregnant, the azithromycin 1 gram one-time dose is also okay, but not preferred. A little bit about counseling. So again, it's important to remind patients about what they should and shouldn't be doing when you're treating them for chlamydia, really any of these sexually transmitted infections. Sexual abstinence for at least 7 days after the 1-dose regimen or after the completion of a 7-day regimen is important. Tested cure is only indicated in pregnancy or if the patient has persistent symptoms or if you're concerned for non-adherence. Typically, tested cure will be completed 4 weeks after the treatment. The CDC did put out some recommendations on their website saying that even though retesting isn't necessary in all circumstances, they do recommend retesting just given the prevalence of chlamydia 3 months after treatment. So we should keep in mind all non-pregnant women should still be getting some sort of follow-up testing within 3 months. In terms of reinfection, repeat therapy with a preferred drug regimen is usually tolerable. So using doxycycline, bacterial resistance has not been documented with either doxycycline or azithromycin. So if the patient gets reinfected, it's likely because they either were compliant with the treatment, their partner wasn't treated, and they were reinfected. It's not necessarily a concern for bacterial resistance to the antibiotics. The next is gonorrhea. So Neisseria gonorrhea is a gram-negative intracellular bacillus. It's the second most common sexually transmitted infection reported in the United States. The incidence rate in 2018 reported on UpToDate was 179 in 100,000 cases, or 100,000 people. Again, the highest rate is among individuals less than 25 years of age. It's important to keep in mind for annual screening for these folks, so ages 20 to 24. Typically, patients tend to be more symptomatic with gonorrhea than chlamydia, so they can have cervicitis within 10 days of exposure, mucopurulent vaginal discharge, intramenstrual bleeding. Urethritis is important to keep in mind. The urethra is the main sign of infection for women who have undergone hysterectomy, so it's important for our post-operative patients when we're doing sexually transmitted infection screening for gonorrhea, PID, perihepatitis as well, and then Bartholinitis, which I think is important to bring up, that if you're treating a patient for what you are suspicious of an infected Bartholin's gland cyst, that swab it for gonorrhea and chlamydia. Make sure that there's no gonorrhea as the underlying infectious organism to the Bartholinitis. Diagnosis is the same: nucleic acid amplification testing, either vaginal swab or urine, and most testing will combine with gonorrhea, chlamydia. The CDC put out new treatment guidelines this year in 2021. So now the recommendation is a single IM dose of ceftriaxone 500 milligrams. If the patient is equal to or over 150 kilograms, then you should increase it to 1 gram IM dose. If they test positive for concurrent chlamydia infection, or you're not able to effectively rule out a chlamydia infection, then you should also treat them with a course of doxycycline if they're not pregnant. And then counseling items for gonorrhea infections. Organisms are eliminated 24 hours after treatment, but the recommendation is still at least 7 days of abstinence after treatment. The CDC recommendation is for no test of cure following treatment for gonorrhea as long as symptoms have subsided, unless it's a case of oropharyngeal gonorrhea, and they recommend a test of cure. However, routine return testing is recommended for all people similar to chlamydia within 3 months after treatment. Trichomonas is a flagellated protozoan that we routinely will see on examinations as an organism on microscopy seen here. It's the most common non-viral STI worldwide. The WHO in 2008 reported 276 million new cases globally, and the prevalence is highest in non-Hispanic Black women. Manifestations include purulent, malodorous, thin vaginal discharge. It's usually described as gray on examinations. The patient may have dysuria, pyuria, PID. Also, thinking about postoperative patients, trichomonas can cause post-hysterectomy cuff cellulitis and abscesses. So remembering to swab the vaginal cuff if you're concerned for cellulitis post-hysterectomy. Diagnosis usually is microscopy, and a lot of us, myself included, I've never seen this in real life, but it typically is diagnosed first with microscopy. You can see alkalinization of the vaginal pH over 4.5. And then you do confirmatory testing with nucleic acid amplification testing, usually with a vaginal swab. As I mentioned before, screening is not typically recommended outside of the HIV population in the first trimester of pregnancy. Treatment, preferred treatment is a 7-day course of metronidazole 500 BID. However, 2-gram one-time dose is permissible, but it's associated with lower rates of cure. So the longer dosing schedule is recommended. Counseling return testing is recommended for all people as soon as 2 weeks to up to 3 months after treatment. Reinfection rates, however, are very high. 17% of women who are treated will end up having a new infection. And then additionally, sexual abstinence is encouraged for 1 week or after completion of treatment, depending on the type of treatment course you select for the patient.